Zone 6 injury. Zone 6 favorable prognosis. Associated joint injury are unlikely. Increase subcutaneous tissue. Lessen the chance of adhesion formation. Sufficient width of tendon. Allow core suture to be easily placed. Greater tendon exertion. Softer tendon repair not lead to restricted joint motion and complete EDC laceration. At this level may not result in MCP joint extensor lag due to tethering effect of the tendon connection. Postoperatively, either static or dynamic splinting may be used. Static splinting involve wrist extension at 30 to 45 degree. MCP joint at neutral to 15 degree of flexion, and IP joint left free to allow active ROM. Dynamic splinting involve wrist extension of 30 to 45 degree. MCP extension and finger are held in extension by trigger attached to a frame by rubber band. This splint is called as extension out trigger splint. Extension out trigger splint. Splint is designed in such a way that when patient performs active finger flexion, passive finger extension occur, allowing early tendon gliding and preventing stretching of delicate extensor tendon. Early phase, that is 5th to 4th week, exercise performed within dynamic orthosis or active MCP flexion with passive extension of PIP and DIP via recoil of rubber band, and active MCP extension with PIP and DIP in hook position. Exercise performed after removal of orthosis to hold wrist and IP joint in 0 degree and passively flex MCP joint to 45. The therapist moves wrist from full passive extension to 0 degree with all finger joint held in 0 degree, with the wrist and MCP joint held in 0 degree by therapist. Wrist and MCP held in 0 degree. Patient actively flexes PIP to 60 degree. At 3 weeks, 60 degree MCP flexion is allowed, and then slowly progress to 75 degree, and then 4 weeks within the confines of orthosis. Intermediate phase at 4 to 5 weeks, splint with the IP joint left free is continued. Active full fist exercise is initiated. Late phase at 6 to 8 weeks, splint is discontinued if there is no MCP extensor lag. If MCP extensor lag is more than 50 degree, nighttime forearm based orthosis is continued for additional 2 to 4 weeks. At 6 weeks, passive range of motion exercise of whole joint and light fine motor activity are begun, and at 7 weeks, progressive resistance exercise are initiated. Zone 7 injuries. In Zone 7 occur at wrist where extensor tendon run underneath the retinoculum. An adequate time of immobilization of 4 weeks in splint or cast is required postoperatively before starting active mobilization. Zone 8 involve musculotendinous junction at distal forearm level, and repair in this zone are quite challenging since muscle fascia is flimsy. Side to side tendon transfer may be